Hello, I am Dr. Khalilah Jefferson, DNP. I am a board certified nurse practitioner. I created this channel to share healthcare education, professional insights, and information about the nurse practitioner role. Here you will find discussions on preventative care, patient wellness, and nursing leadership. Thank you for being here. Bridging the gap, what patients don't know and why that's our responsibility. Modern medicine is extraordinarily complex. We speak in acronyms, algorithms, risk ratios, and protocols. We discuss probabilities, thresholds, and guidelines with fluency, and then we turn to patients and ask a simple question. Do you understand? When they say yes, we often move on. But understanding is not binary. It is not present or absent. It exists on a spectrum, and that spectrum determines outcomes. Health literacy is not a marginal issue. It is a central determinant of health. Patients with limited health literacy experience higher rates of medication errors, poorer chronic disease control, increased emergency department utilization, and preventable hospitalizations. These patterns persist even when access and insurance status are held constant. The gap is not intelligence. The gap is translation. Informed consent, as it is commonly practiced, often satisfies legal standards without meeting ethical ones. Patients sign forms, nod during explanations, and repeat phrases they do not fully grasp. Consent becomes procedural rather than participatory. True informed consent requires comprehension, and comprehension requires clinicians to meet patients where they are, not where the chart assumes they should be. The mismatch between provider knowledge and patient understanding is structural. Clinicians are trained to compress complexity. Patients are expected to expand it without guidance. The result is miscommunication that looks subtle in the exam room but becomes obvious in outcomes. Medication non-adherence is a clear example. Non-adherence is frequently framed as patient failure, lack of motivation, denial, or irresponsibility. Yet qualitative and quantitative studies consistently show that many patients do not take medications as prescribed because they do not understand the purpose, duration, or consequences. Others stop medications due to side effects they were not prepared for or costs they were too embarrassed to disclose. When patients do not understand the plan, they cannot execute the plan. This gap disproportionately affects populations already burdened by disparities. Older adults, individuals with limited formal education, non-native language speakers, and patients navigating multiple comorbidities are systematically disadvantaged by communication that assumes fluency rather than builds it. Health inequity is amplified in the absence of translation. Clinicians often underestimate how much patients do not know. Studies demonstrate that providers routinely overestimate patient understanding, particularly after brief explanations or discharge instructions. The use of medical jargon, even when unintentional, further widens the gap. Effective communication is not about simplifying the truth, it is about structuring it. Translation is a skill. It requires clinicians to identify core concepts, prioritize actionable information, and confirm understanding through techniques such as teach back. Teach back is not a test of the patient, it is an assessment of the explanation. If a patient cannot explain the plan is not complete. Importantly, improving health literacy does not require longer visits in every case. It requires intentional design, clear language, visual aids, repetition across encounters, and alignment between verbal instructions and written materials significantly improve comprehension and adherence. When patients understand, outcomes change. Hospital readmissions decrease when discharge instructions are structured and reinforced. Glycemic control improves when patients understand not only how to take insulin, but why timing and dosing matter. Blood pressure improves when patients grasp the long-term consequences of asymptomatic disease. Understanding transforms passive recipients into active participants. This reframes the clinician's role. Clinicians are not merely conveyors of information. We are interpreters of complex systems. We translate evidence into action. We contextualize risk. We help patients navigate uncertainty. When we fail to translate, we outsource understanding to the internet, social media, and misinformation. The consequences are predictable. Bridging the gap is not optional. It is a professional obligation. It demands humility. the recognition that expertise is meaningless if it cannot be applied. It demands accountability, the willingness to measure success not by what was said, but by what was understood. And it demands equity, the commitment to ensure that comprehension is not a privilege reserved for the most educated or articulate. The future of healthcare will not be determined solely by new therapies or technologies. It will be shaped by whether patients can use what we already know. Knowledge saves lives only when it is shared effectively. And bridging the gap between what patients don't know and what they need to know is not a failure of patience. It is our responsibility.